Ladies and gentlemen, I'm going to dong the bell. That means this meeting has begun. With that, I'd like to recognize Allison Rand of the Woodward Foundation, who is also the co-sponsor. Please stand up and be recognized, Allison. I'd like to recognize our board members that are here and our staff if they'd like to stand up and be recognized. Please do that. And we have our very own drug court judge, David Mattia, with us. Cuyahoga County, please. And also a special guest here today is Dagmar Celeste, our First Lady that helped initiate mental health in Ohio. Please stand up and be recognized. I told Pam earlier that we were talking about Dagmar, that I was going through the old records and I found a letter from Dagmar relative to her speech that she gave about 25 years ago. So welcome back, Dagmar. I've known Pamela Hyde for more than 30 years because I had the privilege of serving with her in the Celeste administration during the 80s. And what I can tell you is she has not changed a bit. She still looks the same. She has the same dedication, the same commitment, and same care for people that we all serve. So I admire that dedication and commitment. She's on a whirlwind trip tour and her job that takes her all over the country. And usually she just comes in a city, does a speech, and she's gone. We have captured her till late in the day, and we're going to visit a number of locations. And she's agreed to do that. So let me do the formal introduction of Pamela S. Hyde. She was nominated by President Barack Obama and confirmed by the U.S. Senate in November of 2009 as the administrator of the Substance Abuse and Mental Health Service Administration, a public health agency within the Department of Health and Human Services. The agency's mission is to reduce the impact of substance abuse and mental illness on America's communities. Ms. Hyde is an attorney and comes to SAMHSA with more than 35 years' experience in management of public health care, human service entities, and agencies. She has served as a mental health director in Ohio in the 80s, where we met her, state human service directors, city housing director, Health Human Services Director, as well as the CEO of a private nonprofit managed behavioral health care firm. She has been recognized by many groups, including the American Medical Association, the National Governors Association, the Seattle Management Association, for her creativity of organizing and leadership in policy and program development and organization of management issues. She has received multiple special acknowledgments and awards for her ability to build teams, develop coalitions, establish strategic plans, and form agendas to achieve identified goals in a constantly changing environment. Ms. Hyde received her law degree from Michigan State University and her bachelor's from Southwest Missouri State University. She also attended the program for senior executives in state government at the John F. Kennedy School, Harvard University. Pam Hyde is an extraordinary individual that we are fortunate to have with us today. She has a lot of friends here, and one of them is not here today. She couldn't be here, Susie Bixel, who is the CEO of JFSA. The reason I mentioned, you did the Ascension program, which is going well and doing an extraordinary job for individuals out at JFSA. So without further ado, let's give Pam Hyde an extraordinary, great welcome to Cuyahoga County in Cleveland.
Thank you, Bill. Thanks, Dan. Thanks, the City Club. Thanks to the Reverends Ben and Corell, and thanks to the Adams Board and all of you in the room. It's great to be back in Ohio. I haven't been here for a while. I do have to just say, though, that Bill's wrong about one thing. If you look at my picture in the agenda there, you can tell that things do change, and I have changed a little bit. Maybe the only thing that hasn't changed, I think I have on the same earrings that were in that presentation or in that picture that day. I also have to do just 2 seconds of telling a story about Dagmar Celeste. When I was a young whippersnapper working for former Governor Celeste, I had an opportunity to drive Dagmar to something. I can't remember what we were going to, but we were in the car for a while. I was driving her. I'd met her, but I didn't know her too well yet. She asked me a question about myself and asked me how old I was, and I told her, and she said, "Oh, you're so young. You have not learned how to fail yet." Well, Dagmar, I got to tell you, I have learned how to fail, and I have learned how to succeed, and I realize that both of them are important. And the work that you all are doing here in Cuyahoga County is definitely succeeding in many, many ways. And yet we all know that we have failures that we have to keep working on. So I'm going to spend just a little bit of time here today talking to you about several things. But I start with just making sure that you all see these messages that we repeat over and over and over again in our world, in the federal world, and that is that behavioral health is essential to health, that treatment is effective, that prevention works, treatment is effective, and people do recover. And we're going to talk about those issues. But what I want to do is do just a little bit of national behavioral health and Ohio behavioral health by the numbers, say a little bit about some of what's going on nationally and in Ohio, and have you see how those connect. I want to talk a little bit about the Affordable Care Act and how that's changing the behavioral health landscape, talk a little bit about recovery and a couple of other things, and then end up talking about what's the relationship with all of this and faith communities. So behavioral health matters to public health. If you think about it, about half of all of us in America will experience a mental health issue at some point in our lives. Half of us. And yet it has been over there hidden in the corner, not talked about. People don't want to admit it. They'll talk about going to talk about their knee. They'll talk about going to talk about their heart. They'll talk about their hypertension. They'll even talk about their breast cancer and their prostate cancer. But people won't talk about their mental health issues, and we've got to change that. We also know at this point that about half of us at any given moment know somebody who's in recovery from substance abuse and addiction, and yet sometimes we don't even know that we know those people. So the point here is this is a universal issue, and that makes it a public health issue. Behavioral health disorders are just like any other health condition. They change biology, they are impacted by biology, they're often comorbid. That's a horrible word, I think, but it's what they use in healthcare. They coexist with physical illnesses, they're preventable, they're treatable, and they are not moral issues. Now, when you put all that together, they're just like any other health condition, and that's important. So the public, unfortunately, still sees behavioral health issues often as a social issue. They see it as a jail issue, as a homelessness issue, as a violence issue, as a disability issue, all of those kinds of things. They see mental disorders often as a public safety issue. They often see substance abuse issues as a moral issue or a matter of will. If that guy would just stop drinking, this would be fine. Well, tell that to someone who has diabetes. If you would just stop eating, if you would just eat differently, it's not that simple. It is about how we're taught to eat. It is about how we are able to get groceries. It is about how there are bike paths in the community. It is about how we are taught about nutrition in schools. There is a ton of stuff that go on about diabetes, and there's a ton of stuff that goes on about behavioral health issues. These are public health issues that have behavioral health implications or behavioral implications, and we have to think of them that way. Now, public attitudes are changing, but they're not there yet. So these data give you just some sense of, there's about 2/3 of the people in this particular survey who thought that treatment and support can in fact help people with mental illness lead normal lives, but that means there's about 1/3 who think they can't. There's about 2/3 that believe addiction can be prevented, but that's about 1/3 who think they can't, that it can't. There's about 3/4 of this particular survey that believed recovery from addiction is possible. Another fourth thinks not. And then when you look at, though, how people report that they will think about people with these conditions, 30% think less of a person with addiction, 20% think less of a friend or relative in recovery, 38% are unwilling to be friends with a person with mental illness. What if I said, are you willing to be friends with a person with a podiatry problem? Are you willing to be friends with someone with breast cancer? Would there be a question? And yet there was a time when we wouldn't talk about breast cancer because it wasn't cool either. There's about 2/3 of people who do not want a person with schizophrenia as a coworker. Quick story here. I don't know how many of you have heard about Ellen, who is a law school professor who has schizophrenia. She is the head of a department of a law school who has schizophrenia. She went to lunch with a person, a colleague, who later learned that she had schizophrenia. And the woman said to her, to Ellen, if I had known that, I would not have gone to lunch with you. I mean, can you believe that? That someone would even say that? And yet that is true. So about 2/3 of people don't want a person with schizophrenia as a coworker. And about 2/3, a little more than 2/3 don't want a person with depression to marry into their family. Well, get over it, because most of us have somebody in our family who's got depression or who's experienced that at some point in their lives. So and there's also some very interesting data that says that people are less willing to ameliorate the condition of behavioral health even when they understand the implications. So they're less willing to pay money to have that condition ameliorated, going to treatment, etc. And that's in large part, I think, because people don't yet think that behavioral health issues can be prevented, treated, and recovered from. So let me give you just a little bit of data about this. The NSDUH, NSDUH, the National Survey on Drug Use and Health, is actually our major surveillance data about both substance abuse and mental illness. I'm going to give you some data from this NSDUH from 2012, our most recent data. And that is that there's about 22.2 million people who have substance abuse or dependence in our country. That's about the same as the number of people who have diabetes. Now, how much do you hear about diabetes these days? A ton. How much do you hear about addiction in terms of a public health issue? You guys probably hear about it a lot more, but not nearly as many people who are willing to talk about that and how to deal with it. For prescription drugs, for non-medical use of prescription drugs, that's actually going down. That's a good thing. What is not going down, what is shooting up, is the opioid overdoses, the pain pills overdoses, the adverse impacts from the increasing non-medical use of pain medications. So we have to distinguish between prescription drug misuse, which is actually getting better, and the adverse incidents, which are getting much worse. Heroin use is going way up, and I'm going to talk a little bit more about that in a minute, but it's almost doubled in the last 5 years nationally, and it's more than doubled the dependence and abuse. The good news is cocaine and methamphetamine use is going down. So we have done something right in this country over the last few years. Alcohol remains the most commonly used and abused substance, with 136 million of us reporting past month use, and about 60 million reporting binge drinking, and about 17 million reported heavy use. The good news here is that for young people, the binge drinking, the early start is going down, except in that college age group. The 18 to 24-year-olds, we still have issues there. Marijuana, I could spend a whole 2 hours on marijuana, but it's the most commonly used illicit drug. And I say illicit because in a few states it's no longer illicit, at least for adults. What we do still know about marijuana, it's the most commonly used illicit drug. It is still very much has a negative implications for young people. So just like we don't want young people to drink before the age of 21, we have to be thinking, as states seem to be moving toward making marijuana use legal for adults, there are still huge issues for our young people. So this gives you just a little bit of a flavor of, if you look at where heroin sits in this particular illicit drug use, what you can see is that it's really not as high as some of the other things, even cocaine, which has been going down, and tranquilizers. However, the adverse events are huge. Here's also for heroin use. In the past month, and past year, for 12 years of age and older, you can see that it has been consistently going up. It spiked in 2006, not sure exactly why, and then came back down in 2007 and has been growing every year since. These are national data. I'm going to talk about Ohio right now. So if you look at the alcohol dependence and abuse rate in Ohio, it's about similar to the national rate. If you look at the treatment for alcohol dependence and abuse, it's also about similar to the national rate. If you look at illicit drug dependence and abuse, that rate is also about similar to the nation. And the treatment for illicit drug dependence and abuse is about similar to the nation. SAMHSA just last year started putting out national barometers and state barometers. You may want to watch those. We're going to try to put those out every year or so, and you'll be able to compare Ohio to the nation and Ohio to other states to see how you fare. So opioid overdoses and deaths. Let me just compare the nation and Ohio just a bit here, because this is where the issue is. The issue about overdoses and deaths is where the rates are going skyrocketing and where we're trying to do some work, and you're doing some work here in Ohio. So in 2010, I have 2010 national data and 2012 Ohio data, and I'm going to tell you why that's important, because if you can see the number of deaths from drug overdose was up from 2009. Now this number of deaths in 2010 from overdose of opioids, which is both legal prescription drug, non-medically used, and heroin, is just about the same as the number of deaths from suicide annually in our country. Now, what that means is 2 behavioral health issues have more deaths than homicide, than HIV/AIDS, than traffic accidents, all the things we talk about and want to reduce. 2 behavioral health issues have more deaths, or have as many deaths or more deaths than any of those. And you put these 2 together and they're humongous in terms of mortality rates. If you look at the deaths attributable to heroin and what the percentage increase was, it's about a little less than 10% of the deaths to drug overdose in general. In Ohio, the death rate also from unintentional drug overdoses was one of the highest you've had, as I understand it, in 2012, a 366% increase from 2000. Now, why is that important? If you can quick do the math here and look at these 2, you're 2 years ahead of us in having the data for Ohio than we have nationally. If your numbers continue to track at the same rate as the nation, in 2012, we will have almost 6,000 deaths, over 6,000 deaths attributable to heroin in this country. So you may be the bellwether here in terms of helping us understand how much this is increasing. It's a huge issue. So this is up there just to say Ohio has recognized this. The Adams Board has recognized this here in Cuyahoga County. You guys are doing a lot of work with it. SAMHSA is doing a lot of work around opioid overdose prevention. We have a national toolkit that's out there. If you've not seen it, I encourage you to go online and get it to samhsa.gov, to our store. We've done work in sending out messages to the states that they can use their block grant dollars for prevention and education about naloxone, which is the opioid overdose medication or that can be used to prevent that overdose death. We have the toolkits, which now has had over 44,000 downloads. And we've been doing a lot of work around what we call medication-assisted treatment, or MAT. So a drug called buprenorphine. We do a lot of training on how to use that medication. And we're working on an options memo with the CDC about how to deal with that issue. We're also pulling some states together in a policy academy in August. There's a ton of this work going on at the federal level with the National Governors Association, with ourselves, with CDC, with the Secretary's Office, and others that you'll see more about. And of course, here in Ohio, you have, and in Cuyahoga County now, you have a major effort called Project Dawn, which I was very interested to see and very interested to read about in terms of trying to get naloxone kits out to people and get education to people about how to prevent that overdose death from heroin and other opioids. I want to spend just a few minutes talking to you a little bit about Americans with substance use disorders and who's getting treated and who isn't. There's about, as I told you earlier, about 22, 23 million persons in the country with substance use issues or that need treatment. Only about 3.7% of them felt they needed treatment. And only of that amount, only about 1.7 of the total actually sought treatment or tried to get treatment. A lot of individuals in this group don't feel like they need treatment, and in part they say that for 2 or 3 reasons. One is because of the cost of treatment, one is because they don't believe it will work, and the third is because they don't know where to get it, where to get help. So we have a lot of work to do to help people understand that treatment is available, that it does work, and now with the Affordable Care Act it is cost effective and can be helpful. When people get substance abuse treatment in the country, this is where they get it. A big proportion get it from self-help groups and from other areas that you all are aware of. So self-help and mutual aid is a huge part of substance abuse treatment and recovery, and that's critical, and we're going to come back to that a little bit when we talk about the faith community. Let me talk about mental illness for a second. In mental health, there's about twice as many people in the country at any given moment who have criteria that meets a diagnosable mental illness. For a serious mental illness, there's about 4.1% of our country at any given moment who have a serious mental illness. For a major depressive disorder, this is pretty high, about 6.9% of our country. And suicide deaths here, you can see this data. By the way, I know I'm throwing tons of data at you very quickly. These slides will be available. The board has them now, and you can make them available on your website as that's helpful to you. The thing I want to tell you about the suicide deaths is that about 1/3 of the suicide deaths have a blood alcohol level. The person has a blood alcohol level above the legal limit. So the connection between alcohol and suicide is huge, and there's an increasing understanding about the connection between illicit drugs or other kinds of drugs and suicide. And in fact, a lot of the conversation about unintentional overdose, we technically don't know that that's true. A lot of times we don't know whether those deaths were unintentional or not. The thing here I also want to point out about suicides, however, is that if you add both adult suicide and youth suicide attempts, there are 11 million people in this country every year who have serious thoughts of suicide. So as much as the 38% mortality or death rate is, or 38,000 is important, I would suggest to you that those 11 million people who are seriously thinking about it are the people that we need to pay attention to. That's where the distress is, and if they take the attempt, if they make the attempt, the death rate's going to go up. The barometer here for Ohio shows that your rates for having serious mental illness are higher than the country, that your rates for treatment for serious mental illness are higher than the country, but your suicidal thought rate, or the rates of number of people with suicidal thoughts, is about the same as the country. So let me talk a little bit about health reform. And I know I'm speeding again through some of this because we want to get to the Q&A part. There's a lot going on in health reform. We could talk about the politics of it all day. What I want to tell you about is that this is more than the Affordable Care Act, although that is clearly driving some of the health reform issues. The health delivery and reform and payment and coverage issues in our country are changing dramatically. And quality is a bigger issue. Cost of care is a bigger issue. Access to care is a bigger issue. The state's role in these decisions is a bigger issue. And congratulations to you here in Ohio who did the Medicaid expansion. It was a very good decision. And recovery and being able to live healthily with chronic conditions is a huge issue. And all of this is shifting. Prevention and wellness is a much major issue. By the numbers, you've seen some of this in the press, but over 8 million people selected plans from state and federal marketplaces in the first open enrollment. We have another one coming up this fall. 7 million young people young people and adults enrolled in Medicaid and CHIP. Many adults, all of these numbers, 7, 8 million, if you put them all together, you can see how many Americans have been impacted by these changes in health reform just in the last year or two. 105 million Americans as of January 1st, had lifetime limits removed from their insurance. And many, many millions of Americans and young people have the ability now to stay on their parents' insurance, and that includes young people with mental and substance use disorders. If you look at the prevalence of behavioral health conditions among uninsured adults, you can see sort of what those percentages are, and in the interest of time, I'm going to flip through this because you guys all know that a lot of uninsured Americans have these conditions. I wanted to show you just a little bit of Ohio by the numbers. As of July of last year, about 1.3 million or 14% were uninsured, and about 94% of them qualified for some help under the marketplace. When, as of the end of March, when you all ended this process of the open enrollment, 154,000 plus made market plan selections, about 208,000 were new enrollees in Medicaid and CHIP. If you put those two numbers together, what you see is that you have made well over a 10 or 20% impact on that uninsured number. Now, there's more to do. We have to continue that process. So this has just been one process and 1 year, and this is going to continue. Here's what I want you to see in the red or the darker color. Ohio is a little bit higher in terms of the number of people with serious mental illness, the number of people with serious psychological distress, and the number of people with substance use disorders among the marketplace population. So it's all the more important that you get people enrolled in that coverage. For the Medicaid expansion population, those same numbers are fairly significantly higher than the national numbers. And so the importance of the decision that your governor and you all made to expand Medicaid is going to be huge for the population we're talking about today. So I know part of what we're discussing is recovery. I'm also going to flip through this very quickly so we can get to those Q&As, but this is the way we define recovery at SAMHSA. We've spent a lot of time, we've spent a couple of years working across the country on what recovery means. And we basically came up with the definition that it's a process of change. That recovery is a process of change through which individuals improve their health and wellness and live a self-directed life and strive to reach their full potential. Now that includes dealing with their health, so abstinence issues, symptom control, that sort of thing. It also deals with their home, having a place to live that supports their recovery, having a sense of community, which means social supports are critical to recovery, and having a sense of purpose, which means a job, education, something meaningful to do in life. So those four elements are a major part of recovery for us. If you look at the 10 guiding principles of recovery, you'll see that one of them is hope. And I'm going to come back to that issue again in the context of looking at faith. Recovery-oriented systems of care is a major program and evidence-based practice that we have that looks at a person in a whole context, and that includes looking at their social services and as well as their treatments. Now, this is a complex slide. I promised the Reverend I would show you this. This is a complex slide that looks at all the elements of the ROSC, or Recovery-Oriented Systems of Care. And what I've tried to pull out for you there, I hope you can see it, is the spiritual aspect of it. We have begun in government to not be quite so worried about saying the word spiritual and faith. That has been a difficult thing for government because we've tried so hard to separate state and church. Nevertheless, consumers and people in recovery have told us that you are missing the boat when you don't include the spiritual part of our recovery. So, recovery in the faith community. Yes, give yourselves a lot of credit. A place of worship is a therapeutic system, if you want to think of it in that way. It allows expression of suffering. It promotes or provides emotional support and acceptance. It cultivates a sense of belonging. And it educates regarding public health problems, interventions, and it instills and fosters hope, which is one of the 10 guiding principles of recovery. Now, that is so critical because faith communities, I think the primary role of a faith community is what I'm going to use my own faith tradition's language, is extravagant welcome. And that is a construct to me that doesn't matter who you are, doesn't matter where you are on life's journey, doesn't matter what you're dealing with, you are welcome in that faith community. And that is a critical part of recovery. Remember, I told you it was about health, home, community, and purpose. If you think of those 4 elements, they're all engaged and involved in faith communities. So some of the roles that faith communities can play is education and awareness of members, of public, even of public policymakers, if you're careful not to cross that line that you're not supposed to cross about lobbying. There can be positive messages in programs and services, educational materials, things like prescription drug take-back days or suicide warnings, signs and symptoms, things of that nature. You can also, as a faith community, do enrollment and outreach activities. I'm going to show you in just a second a couple of examples of that. A lot of prevention activity is possible in your youth programs if you'll just deal with those drug and alcohol issues and deal with suicide issues. I can tell you, the kids are talking about it. We had a young person say to us, look, we're talking about it. I don't care what you think about how you're supposed to talk about it. The kids are already talking about it. They're on social media about it. They're talking about suicide. They're talking about bullying. They're talking about drug abuse. They're talking about mental health issues and depression. So there's lots of opportunities in church and community and congregational and mosques and other places to talk about prevention activities. There's counseling, both lay and clerical counseling. My own pastor said to me recently, you know, we at the church in the church community have essentially given up our counseling role to the professionals, the professional counselors. And there is a role for lay and clerical faith counseling, as well as a very close connection role to referral to the right behavioral health treatment when needed. There's screenings, my goodness. Churches, mosques, synagogues, and others do blood pressure screening. Why can't we do depression screening? I think we can do that if we have those right connections. And paying attention, we are trying in this context to pay attention to the secondary trauma that faith leaders deal with when they deal every day, over and over and over again, with the struggles that people have. We are learning that those faith leaders need special support from their membership and from the community because they're carrying a heavy load for all of us. And then, of course, the faith community can be a source of community and support for recovery, peers, friends, other things. So let me just give you a couple of examples. In the faith community, we had 52 enrollment events were hosted by faith leaders and congregations in which thousands participated. This is just the ones we know about that are behavioral health oriented during the open enrollment period for the Affordable Care Act. I'm sure there were tons and tons more in the general health community. In suicide prevention, we have a National Action Alliance for Suicide Prevention that's working on the national strategy for suicide prevention. It's been going since 2010. There's a Faith Communities Task Force that is developing a campaign called Your Life Matters. So watch for it very soon in social media. They're developing a toolkit of resources for congregations to use that will have prayers and liturgies and sermons and reflections and hymns and other songs about celebrating life. And they're encouraging faith communities to set aside one Sabbath a year to focus on these issues. Mental health first aid is also the idea that we learn from the time we're very little to know something about how to stop bleeding, how to recognize you need to call 911, how to help people who might be experiencing a heart attack or a stroke. We don't do very well at teaching people how to recognize signs and symptoms of mental health and substance abuse issues and how to intervene in appropriate ways. So from July 28th to August 1st, SAMHSA is providing clergy and faith leaders with mental health first aid instructor training to equip congregations with some needed skills. This is available to any church community, any synagogue, any mosque, any congregation that wants to take a look at some of that effort. So SAMHSA is here to help. There's a faith communities part of our website we encourage you to go onto, and that's what this is to tell you. And then just to end up by saying, we really are trying to be here to help the country understand what I said in the beginning, that behavioral health is essential to health, that prevention works, that treatment's effective, and recovery is possible. People do recover, and the faith community is a very critical aspect of that recovery. So with that, let me stop, and we'll try to get to the Q&As. Thank you.
Today at the City Club of Cleveland, we are enjoying a special program with Pam Hyde, Administrator of the Substance Abuse and Mental Health Systems Administration in the U.S. Department of Health and Human Services. We encourage you to formulate your questions for our speaker now, and to remind you that your questions should be brief and to the point, and they should be questions. Tomorrow, June 6th, the City Club welcomes Dr. Barbara O'Brien, Policy Director for the National Campaign for Grade Level Reading. For more information about upcoming and past forums, please visit us online at cityclub.org. Today, we welcome guests at tables hosted by a number of generous partners that are included in our brochure, but also including the Achievement Centers, New Direction, Hispanic Human Cleveland Clinic, and University Hospital, which are not mentioned in the program. We thank you all for your support. Today's forum is presented in partnership with Cuyahoga County Alcohol, Drug Addiction, and Mental Health Services Board and the Woodruff Foundation. We thank you for your support in making today's program possible. Now, we'd like to return to our speaker for our traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphones today are City Club Associate Director of Advancement, Mike Ciraldi, and City Club intern Spencer Kissel. First question, please.
Thank you, Administrator Hyde, for coming to Cleveland. I love the analogy about diabetes. I've used something similar myself. You talked about the stigma of treating people with dependency issues. But unlike diabetes, the infrastructure for treatment, particularly recovery housing, is lacking. Do you have any suggestions as to how a community can take steps to incubate more recovery housing?
Yeah, good question. So how can we incubate more recovery housing? I think first we have to help people understand the necessity for it. So even in terms of how we talk about recovery, to make it clear that home, and that could be either home for a person who's homeless, or it could be home meaning a place that supports the person in recovery. So sober housing, recovery housing, or even housing for people with mental health issues who need a certain kind of structure or certain kind of housing support in order to maintain their living. So first of all, I think it's talking about it. It's working with our public housing authorities. They have a lot more flexibility. In fact, we're working a lot with HUD. They have a lot more flexibility than they think they do sometimes about some of these issues. And then also recognizing that wherever a person lives, doesn't matter where they live, with a family, by themselves, in a specific structure that is paid for in some public fashion, a person needs to make sure that their home and their housing supports their recovery. So being very explicit about that and being clear when a person's leaving treatment, where are you going to go live, and is it going to support your recovery? So I think there's lots of things that we can do. Obviously, we could say anything of a question about what can we do is going to end up with the question of funding and the political will to get that. So that is important too. But trying to connect to mainstream programs is, I think, what we have to do. I think we have to help the public housing authorities and the general housing builders and others understand that the building in the capacity to support sober living is critical, given the numbers that I've just given here today.
Good morning.
Morning.
First of all, I love the slide on the recovery-oriented systems of care. I think that SAMHSA has captured the elements of recovery basically in totality. My question is there a committee at SAMHSA that works with maybe other departments that are not sort of like in the clinical setting to help them understand the shift that's needed, possibly like in grants and funding, so that the regulations are sort of catching up with what is really needed to work with these people?
This is a great question. I think it's a question about partnerships, and I sort of titled the talk here about partnerships in challenging times. SAMHSA is actually a fairly small agency. We're about $3.6 billion, which sounds like a lot, but Medicaid pays out more than that every hour than we have dollars to do. So part of our role is trying to influence and collaborate. So we work a lot with other departments. I mentioned HUD. We're also working with the Veterans Administration or Veterans Affairs Department. We're working with the Department of Justice. We're working with the Department of Defense. We're working with the Department of Labor. So we do a lot of interface with those other departments. And within HHS, we're working a lot with the Centers for Disease Control. We're working a lot with CMS, which is Medicaid and Medicare. We've done a lot of interactive work with them around information bulletins to the states about how they can use Medicaid to support recovery, whether it's supported employment or supported housing or those kinds of things. We're doing a lot of work with the Administration on Children and Families, looking at young people in child welfare, because probably 90% of them are there because of behavioral health issues in their family, either drug and alcohol, trauma issues, or otherwise, and they're heavily psychotropically medicated, many times inappropriately, when there could be other kinds of services provided that are more recovery oriented. So we're doing a lot of that kind of work. So the quick answer is yes, we do a lot of work to try to infuse in other agencies the issue of mental health and substance abuse recovery and constructs of that nature. And I can tell you, I have a great administration to work in. They are all begging for this stuff. In fact, they're doing work beyond what we can keep up with. So at the moment, the good news is we have more partners than we can keep up with in many ways. So yes, and I assume you're doing that here in Cuyahoga County. There's multiple parties here. I encourage you to do that same thing.
Morning.
Morning.
Thank you for being here. Appreciate it. In the hood, we are dealing with a major issue around community violence. And myself and many of clinicians that I work with have found that it have been non-traditional groups that may not be able to articulate or define and message their work have been so successful in dealing with the issue around violence and those issues that lead up to violence in our community. What is SAMHSA doing in terms of helping to bridge the gaps? I find that in many cities throughout the country, this gap is not closing, and the cultural competency and an ability to understand how these non-traditional organizations with very little, no funding are able to maximize and deliver measurable results that sometimes get caught up in the bureaucracy or whatever's going on in terms of institutional approaches. What are you doing to help bridge that gap?
Yeah, that's also a great comment or question, and thank you for asking it, because I think what we've come to understand is that we can talk to ourselves all day, and it only goes so far, and that we do have to get to the non-traditional partners in the community who care about their community. If you ask multiple players in the community, parents, school professionals, businesses, faith leaders, and others in the community, what's one of the most important things in their community, the first thing they'll say often is safety. I want my kid to be able to ride their bike without worried about being beaten up or shot or snatched or whatever else. Businesses have humongous interest right now in improving health, and as they look at improving health, because it improves productivity and it improves the community in which they work and try to make a living and try to make a profit. If you look at that, what they realize is that alcoholism and substance abuse more broadly and depression are three of the biggest issues that affect productivity in their community, in their community of business, in their employees. If you talk to parents and first responders and others in the community, this issue of violence in the community and the trauma that it does to our young people, to all of us, but especially to our young people, it has lifelong implications. We were talking about this a little bit earlier, when you're 12 years old and you've already seen 6 people die in front of you, either from a drug overdose or from a gang shooting or something, it has lifetime implications, not just on your emotions, but literally on your brain. The National Institute of Drug Abuse, the National Institute of Mental Health, the National Institute of Alcohol have been working on this issue of the implications of trauma on the brain and how the brain affects trauma and how the resilience and how trauma is affected by or how trauma affects the brain. So sort of easy to go off into that science, but my point is that you are doing the right thing to try to engage these non-traditional partners. And I can tell you business is interested. If you go talk to them, and I think part of it is, if anybody's a fundraiser in the room, and I know anybody in a nonprofit world is a fundraiser, you know that you don't get money unless you ask. Well, you don't get help unless you ask. If you go ask the business leaders, the faith leaders, and others, and give them a way to help, I think they will be there in a heartbeat. We just last week, in fact, just this week, our Center for Mental Health Services director was on a call with some of the leaders in HHS and some business leaders in the nation who are trying to look at this issue of health in the workplace, and they were particularly interested in behavioral health issues because of community violence, because of worker productivity, because of what they can see the implications are about healthcare costs to them. So we're doing a lot in that regard, but there's only so much we can kind of sort of set the stage. But, you know, it's in your community. It's your business person down the street. It's your school down the street. What we can provide is resources, training. We can provide information. Sometimes we can provide connections. If there's anything like that we can be helpful to, we would like to do that.
Question representing the prevention community. I remember very vividly a statement you made a couple years ago that we have to find credible new ways to reach young people in our community. Yeah. And I had found a program that was produced by the National Institute on Drug Abuse called Brain Power. And my question to you is, do SAMHSA and NIDA collaborate on any projects like this? Because I'm trying to figure out why NIDA is not on the SAMHSA approved list of programs. That's one of the stumbling blocks I find when I'm out speaking to schools is finding money for this. Well, here's this wonderful program that our tax dollars have created, but yet it's not on that SAMHSA supported list. And I was hoping you could speak to that process, how NIDA and SAMHSA work together and how we might accomplish something like that.
Yeah, NIDA and SAMHSA work a lot. Nora Velkow is just terrific. We work together a lot. In fact, they actually give us money to try to take stuff to scale. So to the extent that they research something and it seems to be working, they sometimes give us dollars to help with technical assistance and things of that nature. The National Institute of Mental Health and we are collaborating right now on the 5% set aside for the block grant about early serious mental illnesses. So we collaborate with the institutes quite a bit. I think you may be referring to NREP, our National Registry of Evidence-Based Practices. This is a very small program. I wish we could grow it tons, but we have very little dollars for it. And it's a voluntary program, which means that a designer of a program has to bring the program to us and say, would you please review this? And there's basically two criteria for getting into the program and getting listed, one of which is the research sufficient? So sometimes you can have research in one place, but it's not necessarily sufficient to say it's replicable everywhere. And then the second criteria is there some way, materials or otherwise, to replicate it? So that's the two things that we look at, and it's truly voluntary. So it's not like we go out and pick the 10 best programs. It's like whoever came to us and said, would you please review my program? And I know there's at least one or two people in the room who have tried to get through that process and know that it's a little bit cumbersome. And the reason for that is to make sure that we've got the research behind it and that we've got the replicability behind it. So if you've got a program you think we should be looking at, let us know. It's a NIDA program. So somebody who helped create that program that NIDA researched would have to bring it to us and ask us to put it through the process. But if you'll give me the name of the program again, I'll check and see if there's some. Okay.
Hello.
Hi.
I'm wondering if you've considered adding addiction to one or more foods to our national response to substance abuse.
Actually, this is a great question. This is addiction to food. Actually, NIDA is doing some work around, and the other National Institutes of Health are doing some work around addiction to sugar, refined sugars, and looking at the brain connections and now I'm not the scientist here, so forgive me, but my understanding is, at least first impressions, that the addictions to sugar are acting on the same brain receptors and creating the same kind of addiction, that addiction to alcohol. And alcohol obviously has tons of sugar in it. I think there is some interest in that, especially as the nation has looked at diabetes and obesity issues and the health relationships. The good news is, for the first time, our generation of young people are actually way less than, or there's less obesity than the last generation among the younger kids. So I think we're making a dent, but we've got ways to go.
Hi, this probably is a combination of your Health and Human Service hat and your SAMHSA hat. You know, is there anything being talked about as far as the IMD rule that's kind of an obstacle to us providing services now for drug and alcohol? I know a lot of people across the nation are looking for it to be overturned, and didn't know if you had any information on that.
Yeah, the IMD rule is a great question. The IMD rule is called the Institutions for Mental Disease. That's what IMD stands for. It is an exclusion in Medicaid that has been there from the beginning of the Medicaid program. It is a congressionally passed, and it was put into the program from the very beginning, exclusion. It goes all the way, exclusion meaning states cannot get federal Medicaid dollars for individuals who are served between the ages of 18 and 64. So young people and older people this doesn't affect, but between 18 and 64 who are getting treatment for behavioral health issues in an institution for mental disease. That was basically put into effect because back in the day when Medicaid was first implemented by our Congress with some of the same kinds of arguments that are being argued about with ACA today, but that's another matter. It was because most of that treatment was being done by states in state-run facilities. That's primarily where, in state hospitals basically, that's primarily where behavioral health services were being provided. And frankly, the federal government at the time didn't want to take over payment for things that the states were doing. And there was also a lot of concern about the effectiveness of that treatment. Because just like people argue today sometimes people are put into those facilities for reasons that have less to do with their treatment and more to do with their legal status or other issues. So there were lots of issues about that. So it was excluded from the beginning. There is a demonstration that's going on right now that CMS is doing as part of the ACA. So it was put into effect in the Affordable Care Act to demonstrate what would happen if they changed the IMD exclusion for certain groups of people in certain contexts. That demonstration isn't done yet, so they don't have the results of it yet. The first report is going to Congress soon, but frankly, Congress wants those reports in a year, and you all know that sometimes you can't get the data that quickly. So that's going on. In the meantime, there's a lot of discussion about what the implications of that are. So the implications of institutions for mental disease or IMD exclusion, I think have been said to be that there's not enough hospital beds. I think there's a lot more reasons why there's not enough hospital beds or why there are not enough crisis services. That is a major issue for our country for both substance abuse and for mental illness. So people end up sitting in emergency departments in regular hospitals. They get boarded there for long periods of time, meaning just sit there waiting for a bed to open or whatever because there's not sufficient crisis services. So my point in that, it's a very complicated area, is that there's a lot of work going on with CMS and Medicaid helping states to understand how they can use their Medicaid programs to support more comprehensive crisis interventions for both individuals and their families. And those crisis interventions have to not only deal with the crisis at the moment, but they have to do the right follow-up to make sure the person doesn't just keep repeating and that the family's issues are dealt with as well. Now, the larger issue of things like residential treatment and other things of that nature, which are sometimes excluded or not paid for because of the IMD exclusion, at least not paid for by Medicaid because of that, is also being looked at in the context of parity. So Medicaid is going through right now the process of the Medicaid parity reg. It's probably going to be another year or so before that is out, but that's also a consequence of the fancy name we call MAPIA, or the Mental Health Parity and Addiction Equity Act. So this is a fairly complicated area, but the long and short of it is, yes, we're very aware of it. Secondly, it has historical roots as well as real roots, and we're also looking at ways around that issue that are more potentially more effective or helpful. We also have to understand that this is only Medicaid. There are other rate issues, and which have historical roots and people understanding the value of those services. So SAMHSA just supported something called an Assessing the Evidence Base series in the Psych Services Journal. So if you look at that, in fact, I think it's coming out in July as the last one, a whole series of looking at what's the evidence behind certain services, and residential treatment is one of the ones that we put in there. So there's more research that needs to be done about what kinds of people benefit from residential services and what kinds do not, and where we should be focusing those dollars. So again, I could talk about this for 3 hours, but I think you get the point that, yeah, we're working a lot on that. We're working with Medicaid on that. Medicare is another whole complete ball of wax, because Medicare does not have parity at this point. It's not required to have parity by law, and has some other implications. So they don't provide as many mental health services except in the disability part of Medicare. So more on that at some other time when you invite me back. But at this, I think we'll go to Bill.
Today at the City Club, we have been listening to a special forum with Pam Hyde, Administrator of the Substance Abuse and Mental Health Services Administration, Department of Health and Human Services. Thank you, Ms. Hyde. Thank you, ladies and gentlemen. This forum is now adjourned.